Okay, so let's try a quick word association game to start us off.
Hmm.
If I say gallbladder problems or, liver issues, what's the immediate image that pops into your head?
Ideally, I'd say something clinical, like complex physiological system, but realistically, probably a middle-aged guy, someone who loves greasy cheeseburgers a little too much, maybe enjoys a few too many beers on the weekend.
Right, exactly. We have this really strong cultural association that biliary problems, gallstones, sluggish livers, they're diseases of lifestyle, that they're just the inevitable wear and tear of getting older.
Yeah, that's the standard assumption.
But today, we are taking that assumption and just completely tossing it out the window.
We really are. We're looking at a totally different patient demographic today. We are talking about children, infants, toddlers, and even babies still in the womb.
And based on the research we're doing for this deep dive today, this isn't just mini adult medicine, is it? It's not the same diseases just scaled down for smaller bodies.
Not at all. And that is probably the biggest misconception we need to clear up right out of the gate. In adults, the biliary system is like plumbing that gets clogged up over decades of use. But in children,
It's totally different.
it's a factory error. It's a world of missing parts, double parts, weirdly shaped parts, and in some cases, some very loud ticking clocks.
To navigate all of this, we're unpacking a really comprehensive medical review. It's titled Biliary Disorders, Anomalies, and Malignancies in Children, and it was published in the journal Radiographics in 2024. Now, Radiographics is a radiology journal, which I think is a really crucial detail here for you listening. Why focus so much on the imaging side?
It's crucial because of the patient. I mean, you can't exactly ask a 3-week-old baby, hey, does it hurt under your right rib cage?
Right, they can't tell us a thing.
Exactly. Or how long have you felt nauseous? So the entire diagnostic process relies heavily on imaging. It relies on seeing inside the body to solve these anatomical puzzles without ever making an incision.
Which is why this source is so incredibly valuable. It's essentially a visual guide to the mysteries of the pediatric liver and gallbladder.
Yeah, a fascinating mix of embryology, high-tech physics, and high-stakes surgery.
So our mission today is to explore those mysteries. We're going to look at how a baby's biliary system can go wrong, from embryologic glitches to dangerous blockages, and how doctors use some pretty advanced tech to figure it out before it's too late.
Sounds good.
Let's start with that mini-adult myth I mentioned earlier. The source draws a really hard line in the sand regarding what actually causes these problems in kids versus adults.
Right, so in the adult world, if you have a biliary issue, it's usually one of two things. It's either stones, usually cholesterol stones from your diet, or it's neoplastic, which means tumors.
Which is the scary C word.
Often, yes. If you see a mass in an adult's bile duct, your absolute first thought is cholangiocarcinoma, bile duct cancer. It's aggressive and it's frightening. But the source makes this point very clearly in children. Biliary disorders are overwhelmingly embryologic or congenital.
Meaning the blueprint was just wrong from the start.
Exactly. It's a developmental anomaly. Something went wrong while the organs were actually forming. And here's the good news. Malignancy is incredibly rare. If you see a mass in a child's biliary tree, it is almost never bile duct cancer.
Well, that's a massive relief. But they do get tumors, right? Because I saw rhabdomyosarcoma pop up in the source notes.
They do, but the culprit is totally different. Rhabdomyosarcoma is a soft tissue tumor. It arises from primitive muscle cells, actually. Now, it accounts for only about 0.5% of all childhood solid tumors, so very rare.
But it is the most common biliary tumor in kids.
Yes, and it likes to grow at the hepatic hilum. That's the main doorway where the bile ducts exit the liver. Because of that location, it causes big problems fast. It blocks the flow of bile, and the kid turns yellow. Jaundice.
But the key takeaway for anyone listening is that if a doctor sees a mass there in a child, they aren't treating it like adult cancer. The chemotherapy, the whole playbook changes because the enemy is different. So the disease is different. The biology is different. Does that mean the way we look for it, the actual tools we use, has to change too? I assume you can't just use the exact same scanners.
You really can't. You have to remember who your patient is. You have a developing body with rapidly dividing cells. And this brings us to the golden rule of pediatric imaging, which the source mentions repeatedly, ALARA.
ALARA. As low as reasonably achievable.
Precisely. It refers to the radiation dose. Children are far more sensitive to ionizing radiation than adults are. Their cells are dividing so fast that radiation can cause DNA damage that leads to cancer decades later. Plus, they just have a longer life expectancy ahead of them for those problems to even manifest.
So you can't just throw them in a CT scanner every time they have a tummy ache.
You really shouldn't. CT scans are amazing for detail, but they carry a heavy radiation load. In this radiographics review, they emphasize that CT is almost never the first choice for biliary issues in kids.
When would you actually use it then?
You basically only use it if there's been major trauma, like a car accident, or if a surgeon needs a very specific map of the blood vessels right before a complex operation.
So if CT is kind of the villain here, or at least the absolute last resort, who's the hero?
Ultrasound is king.
Yeah, the source was practically singing the praises of ultrasound. But isn't ultrasound kind of, I don't know, grainy?
It can be, but think about the sheer benefits. It's cheap, it's portable, you can roll it right up to the neonatal incubator, and most importantly, zero radiation. It's just sound waves.
Right.
And there's another huge factor that people often forget. No sedation.
Oh, that is a big deal.
Huge. To get a good CT or MRI, you need the patient to be perfectly, absolutely still. Have you ever tried to tell a 2-year-old to hold their breath and not move a muscle for 30 minutes?
Yeah, possible. You literally have to knock them out.
Exactly. So you have to sedate them, which carries its own serious risks. Ultrasound doesn't require that. But the source also points out that pediatric ultrasound has seriously leveled up. We aren't just looking at grainy black and white snow anymore. They're using inverted 3D images.
I saw that in the paper. It looked almost like a casting. Can you explain what that actually is?
It's a fantastic visualization tool. Imagine taking the fluid-filled structures, the gallbladder and the ducts, and using software to flip the image so the fluid itself looks solid. You get this rotating 3D model of the plumbing system.
So it's like a mold of the inside.
Exactly. It allows a surgeon to see, okay, the duct twists right here, it narrows down there, all without making a single cut.
That is incredible. But what happens when ultrasound isn't enough? Because sound waves can't see through bone or bowel gas very well.
Then you bring in the heavy hitter, MRI, specifically something called MRCP.
Magnetic resonance cholangiopancreatography. I practiced that one.
And you nailed it perfectly. MRCP gives you incredible anatomical detail, very similar to a CT, but with zero radiation. The catch is the motion issue we mentioned. You usually do need anesthesia for the little ones. But the source mentions a really cool trick with MRCP involving contrast agents.
This is the hepatobiliary specific contrast. How is that different from the regular dye they inject?
Great question. Standard MRI contrast just shows you anatomy, what things look like structurally. But if you use the specific hepatobiliary contrast, the liver cells actually pick it up actively and excrete it into the bile. So you can literally watch the flow, you can see function.
Oh, I see. So you can see if the plumbing is actually moving the fluid.
Exactly. Is the liver working? Is the bile moving down the pipes? That is a total game changer for diagnosing blockages.
So we have the tools now. Safe sound waves first, high-tech magnets second, radiation only if absolutely necessary. Let's talk about what we're actually finding with these tools. You mentioned factory errors earlier.
The origin story.
Right. The source takes us way back to the 4th week of gestation.
It's amazing to think about. You are the size of a grain of rice, and your body is trying to build a liver and a gallbladder from scratch. It starts as these 2 tiny buds growing off the primitive gut tube. The pars hepatica becomes the liver, and the pars cystica becomes the gallbladder.
And this is a really complex dance. They have to grow, rotate, and fuse correctly.
And if that pars cystica bud doesn't get the memo, you get gallbladder agenesis.
The case of the missing gallbladder.
It just never forms. The source says this happens in about 10 to 65 people per 10,000.
That seems shockingly frequent to me. I mean, we treat the gallbladder like a standard issue part of the human kit. If you're missing it, does that ruin your digestion?
Surprisingly, no. The funny thing is, most of these kids are totally fine. We call it asymptomatic. We usually just find it by accident when looking for something else. But then nature sometimes does the exact opposite. Instead of 0 gallbladders, you get 2.
Gallbladder duplication. 2 separate gallbladders.
It's rarer, about 1 in 4,000, and for some reason we don't fully understand it's more common in girls.
So walk me through the logistics here. Do they share a duct? Do they work independently?
That is the million-dollar question for the surgeon. Sometimes they share a Y-shaped duct. Sometimes they have completely separate plumbing going into the main line.
And why does this matter? Is having 2 gallbladders inherently bad?
Not inherently, no. But imagine you're a surgeon going in to remove a gallbladder because it's full of stones. You take out the one you see. You don't realize there is a second one tucked right behind it.
Oh, wow. So you literally leave the problem behind.
Or worse, you don't understand the wiring and you accidentally cut the duct for the other gallbladder, causing a massive bile leak into the abdomen.
That sounds like a lawsuit waiting to happen.
Which is exactly why that preoperative imaging, that MRCP map, is so vital. You have to know if you're dealing with a duplicate system before you start driving the car.
Then there's the anomaly that sounded physically painful to me when I was reading, the intrahepatic gallbladder.
This is when the gallbladder gets stuck inside the liver tissue during development. Usually, the gallbladder hangs off the bottom of the liver like a little pear. In this case, it's completely encased in the liver meat.
I imagine that causes major problems with squeezing.
Exactly. The gallbladder is a muscle, essentially. It needs to contract to squirt bile out. If it's buried in solid liver tissue, it can't squeeze properly. That leads to stasis. The bile just sits there.
And stagnant fluid is the enemy.
Always. Stasis leads to stones. So you have a child developing gallstones, not because of what they're eating, but because their gallbladder is physically stuck in a wall.
And then we have the shapes. The source mentions something called a Phrygian cap.
Ah, the Phrygian cap. It sounds exotic. It just means the gallbladder's folded over on itself, looking kind of like a specific type of ancient hat. It's usually harmless. But sometimes these folds or septations act like a kink in a garden hose.
A bottleneck.
Right. And again, bottleneck means stasis. Stasis means stones.
It's amazing how much variation there really is. It's not standard issue human at all.
Not at all. And we haven't even touched on the pancreas yet. There is a condition called pancreas divisum that the source highlights pretty heavily.
This is a failure of fusion, right?
Yes. Embryology 101, the pancreas actually starts as two separate pieces, a dorsal bud and a ventral bud. They are supposed to rotate and fuse into one solid organ around week 8. In pancreas divisum, they just don't fuse. They stay separate.
And so the plumbing doesn't connect.
Correct. Normally, the main pancreatic duct joins the bile duct, and they drain together into the intestine through a nice wide opening called a major papilla. In divisum, because they didn't fuse, the majority of the pancreatic juices try to drain through the minor papilla.
Minor implying very small.
Very small. Imagine trying to drain a full bathtub through a drinking straw.
That creates massive back pressure.
Exactly. And that leads to recurrent pancreatitis. So you have a child who keeps getting inflammation of the pancreas, which is a very painful condition. And the culprit is this failure of fusion that happened just weeks after conception.
The source mentioned a specific sign for this on the MRI, didn't it?
The crossing sign. Because the ducts didn't fuse, they appear to literally cross over each other on the scan without joining. It's a subtle finding. But if the radiologist spots it, you've solved the mystery of the kid's pain.
Incredible detective work.
Okay.
Okay, so those are the glitches, the quirks. But there is one condition in the source that felt much, much more urgent. The ticking clock. Biliary atresia.
This is the big one. If you take nothing else away from pediatric biliary disorders, you have to remember biliary atresia. It is the leading cause of liver transplants in children globally.
So what is it exactly happening in the body?
It is a progressive inflammatory destruction of the bile ducts outside the liver. We don't fully know why it starts. Maybe it's a virus, maybe it's an autoimmune response, but the result is severe fibrosis, scar tissue. The ducts basically shrivel up and obliterate.
So the liver's making bile.
And it has absolutely nowhere to go.
Right.
It can't get to the intestine to help digest food, so it backs up into the liver. And bile is toxic to liver cells if it just sits there. It starts poisoning the liver, causing cirrhosis very, very quickly.
And the main symptom is jaundice. Yellow skin, yellow eyes. But here's the tricky part that I think a lot of parents would wonder about. Babies get jaundiced all the time. My nephew turned a little yellow for a few days after he was born.
And that is exactly the dangerous trap here. Physiologic jaundice is incredibly common. The liver is just waking up, figuring out how to process bilirubin. It usually clears up entirely by week 2 or 3.
So what's the red flag?
The siren that should go off in a parent's or doctor's head is jaundice that persists beyond 2 weeks.
If the baby is still yellow after 2 weeks, you can't just wait and see anymore.
You absolutely cannot wait. You have to move. But diagnosing it is really tricky because you have to differentiate it from neonatal hepatitis, which is just an inflammation of the liver, not a physical blockage.
And this is where that HID scan comes in.
Right. HID is a nuclear medicine test. We inject a radioactive tracer into the baby. The liver pulls it out of the blood. Then we watch with a gamma camera. If the ducts are open, we should see that tracer move down into the intestine, basically. It should light up the diaper area on the scan.
And if the diaper area stays dark,
it means nothing is getting through. That strongly suggests atresia. The ultrasound plays a big role here, too. The source talks about the triangular cord sign.
I wanted to ask about that. It sounds quite ominous.
It's a very specific visual. At the doorway of the liver, exactly where the bile duct should be, the ultrasound shows a triangular-shaped area of high echinogenicity, meaning it's bright white. That triangle is the fibrous remnant. It's the literal scar tissue left behind where the duct used to be.
Okay, so you see the triangular cord, the HID scan shows no flow. You diagnose biliary atresia. Why did we call this a ticking clock?
Because of the 60-day rule. The source emphasizes this heavily. The outcomes for these babies are drastically better if they are surgically treated within the first 60 days of life.
2 months. That is a tiny, tiny window to notice the jaundice, do the scans, and get to surgery.
It is. If you catch it in that window, surgeons perform what's called a Kasai procedure, technically a hepatoportoenterostomy.
Which means
They remove the shriveled up ducts and basically take a loop of the small intestine and hook it directly up to the raw surface of the liver.
just bypassing the broken plumbing entirely.
Exactly. They create a new drain. It allows the bile to flow directly into the gut. Now, I want to be very clear here. This is rarely a permanent cure. Most of these kids will still need a liver transplant eventually, but the Kasai procedure buys them time.
It bridges them.
Right. It bridges them to childhood or adolescence when a transplant is safer.
But if you miss that 60-day window,
The liver is often too scarred. The cirrhosis is too advanced by then. The Kasai won't work. Those babies need a transplant urgently, which is a much more dangerous path for a tiny infant.
that puts so much pressure on that initial diagnosis. Is it normal jaundice or is it atresia?
It is a massive high-stakes question, and it's why radiologists look so hard for that triangular cord sign.
Let's shift gears a bit to something visual that really stood out in the paper. Balloons in the bile ducts. Cholestatic cysts.
Yes, these are structural weaknesses. The bile duct wall is weak, and it balloons out, creating a fluid-filled cyst.
The source had a theory about why this happens, and I have to say the mechanics of it are kind of visceral.
It's a reflux theory.
Yeah,
It is
yeah.
fascinating. The theory is that the junction where the pancreatic duct meets the bile duct is anomalous. It's too high up, creating this long, common channel before it hits the intestine.
And the pressure is different between the two.
Exactly. The pressure on the pancreatic duct is inherently higher. So those powerful pancreatic enzymes, which, remember, are designed to aggressively digest proteins and fats, they flow backward, they reflux up into the bile duct.
So the pancreas is basically trying to digest the bile duct.
Essentially, yes. It eats away at the duct wall, weakening it until it balloons out like an overfilled tire. The source uses the Todani classification to sort these. There are 5 different types.
Type I is the most common one, right?
Correct.
Yeah.
Type I is that classic fusiform dilation of the common bile duct. But then you have type V, which is really its own distinct disease called Curley disease.
Curley disease. This one seemed really complex.
It is. In Curley disease, the cysts aren't in the main duct outside the liver. They're entirely inside the liver. The intrahepatic ducts are dilated and cystic.
And there was a specific imaging sign for this one, too. The central dot sign.
It's a beautiful, albeit pathologic, finding. Imagine looking at a cross-section of the liver on an MRI. You see a dark circle, which is the dilated, fluid-filled duct, and floating right in the dead center of that circle is a tiny, bright dot.
What exactly is the dot?
It's the portal vein. The bile duct has actually wrapped all the way around the vein as it dilated. It confirms for the radiologist that this is a communicating cyst, not just some random fluid collection.
That's amazing detail. And Curley disease often comes with other baggage, doesn't it?
Unfortunately, yes. It's genetic, and it's heavily linked with polycystic kidney disease. So you have a child dealing with severe liver issues and kidney issues simultaneously. And the big risk with all these cysts, whether cholestatic or Curley, is cancer.
The source mentioned cholangiocarcinoma again here.
Right. We said earlier it's rare in kids. But if you leave a cholestatic cyst in place, the chronic inflammation from that refluxing pancreatic juice and the stagnant bile increases the cancer risk massively as they hit adulthood.
So even though it's technically a benign cyst, you take it out anyway.
You have to. It's totally preventative.
Got it. Okay, let's talk about something I thought was purely an adult problem, gallstones. But the source explicitly says kids get stones too.
They do, though it's pretty rare under age 10. But the actual chemistry of the stones is completely different.
How so?
If you or I get stones, they are likely yellow.
Yeah.
Pure cholesterol. We eat too much fat, our metabolism slows down. In kids, the stones are usually pigmented, meaning black or brown.
And what makes them black?
Bilirubin, the breakdown products of blood. This is why there is such a strong, undeniable connection between sickle cell disease and pediatric gallstones.
Oh, connect that for us. How does that work?
In sickle cell disease, the red blood cells are misshapen and very fragile. They break down constantly a process called hemolysis. This floods the child's system with bilirubin. The liver does its job and clears it into the bile, but the gallbladder just can't handle that massive chemical load. The bilirubin precipitates out like rock candy, and you get these hard black stones.
The source had a staggering stat on this.
25 to 30% of sickle cell patients have stones by young adulthood. It's so common that surgeons often remove the gallbladder prophylactically if they are already in the abdomen for something else, just to avoid future emergencies.
That makes perfect sense. Speaking of complications, we need to touch on ascending cholangitis.
This is a nasty infection. It's bacteria literally climbing up the ladder. It's very common after that Kasai procedure we talked about for Atresia.
Because you hook the intestine directly to the liver?
Exactly. You fixed the flow problem, but you removed the natural valve system. Bacteria from the gut now have a free, open highway to climb right up into the liver. It causes high fever, pain, and can be life-threatening. Medicine is so often about trading a big problem like liver failure for a manageable one, like infection risk.
Before we wrap up the bad things list, I want to circle back to rhabdomyosarcoma just for a second. We mentioned it's the most common biliary tumor earlier.
Right.
The source mentioned that because of its location, it really mimics other things on the scans.
It does. It sits right at the hilum, blocking flow. So on a basic ultrasound, it can look a lot like a cyst or even a weirdly placed stone. It's highly deceiving.
So how do they definitively catch it?
MRI again. On the MRI, you can see that it's a solid mass that enhances, meaning it lights up brightly when you give contrast dye. A cyst wouldn't do that. And distinguishing this is absolutely vital because, as we said, the prognosis is tough, but it is treatable with chemo. If you mistake it for a benign cyst and just watch it, you lose critical ground.
So we've covered a lot of ground here today. We've gone from missing gallbladders to double gallbladders, from cysts ballooning out to ducts completely closing up.
It really paints a vivid picture of the pediatric biliary system as this fragile minefield of development.
If we have to synthesize all this for the listener, what is the core takeaway?
I think the main takeaway is that in this specific niche of medicine, anatomy dictates destiny. In adults, we talk about diet, exercise, lifestyle modifications. Here, the die is cast in the 4th week of gestation. A bud splits when it shouldn't or doesn't fuse when it should, and that child's entire medical path is altered before they take their first breath.
And the shift from medical curiosity to full-blown emergency is so fast.
Incredibly fast. A missing gallbladder is a curiosity. Biliary atresia is a sprint against the clock. The radiologist's job is to tell the difference, often using nothing more than sound waves and magnetic fields to keep that ALARA safety principle intact.
It's really impressive detective work. It's connecting the dots between ancient embryology and a single pixel on a screen.
It truly is.
Now, before we go, I want to leave everyone with a thought from the source that kind of blew my mind. We talked about how all these conditions are rare, right?
Correct. Most of these are 1 in 10,000 type numbers, very rare.
But the source mentioned one specific anomaly: the low insertion of the cystic duct. Basically, the duct drains much lower down than usual. It predisposes you to pancreatitis because it messes with the fluid dynamics.
Right. It's a subtle plumbing variation.
The source says this occurs in 9% of patients.
Nearly 1 in 10.
1 in 10. That's not rare. There's probably someone listening to this right now. It really leaves me wondering how many of us are walking around with these subtle embryologic variations. A low duct, a weird fold, a tiny septum, completely unaware.
We all assume we are textbook normal until a very specific set of circumstances, a certain infection, a dietary change triggers a problem.
Are we all just walking anatomical variants waiting to be discovered?
Based on the thousands of scans I've seen. Most likely, yes.
Well, on that slightly unsettling note, thanks for diving deep with us today.
My pleasure.
See you next time.